Hello everyone. Today we are going to start with another topic, that is peptic ulcer. So whenever we talk about peptic ulcer normally occurs in your GIT, that is your gastrointestinal tract. And in your GIT, whenever there is any abnormal area in your GIT of your mucosa of your GIT, or there has been any erosion of your GIT, it will lead to peptic ulcer. So let us see what peptic ulcer is. Peptic ulcer is an abnormal area of your mucosa that has been damaged, and normally which has been damaged, and this damage occurs due to your pepsin being released and your hydrochloric acid of your gastric juice. Along with your peptic ulcer occurring, there is going to be consequent inflammation because there is damage, so inflammation is going to take place in your surrounding and your underlying tissues of your mucosa as well. The most common peptic ulcer is your duodenal ulcer, or your occurs in your duodenum, okay, followed by that of your stomach. And your ulcers can also occur in your esophagus if there is your reflux of your gastric content, that is your gastric contents moving upwards towards your esophagus. In that case you may have your esophageal ulcers as well. So mostly it is because of your low acidic pH which goes and which damages your mucosal layer. Okay, so your secretions, your gastric secretions, normally there is a secretion of your pepsinogen which is secreted by your chief cells, secretion of your HCl and your intrinsic factor which is secreted by your parietal cells, gastrin secreted by your G cells, mucus and your bicarbonate be secreted by your mucus secreting cells. So we are going to see your regulation of your gastric secretion. So whenever we talk about regulation of your gastric secretion, we are talking about regulation of your secretion of your H plus ions from your parietal cells. Okay, so this H plus ions, when it escapes from your parietal cell, it enters into your stomach. This H plus ions interacts with your chlorine ion and then it forms your HCl. So we are going to see how your secretion of your acid secretion in your stomach or is in your stomach is being maintained. So your regulation of your acid secretion is maintained by centrally as well as by peripheral factors. Okay, central factor as well as peripheral factors can determine your secretion of your HCl. When we say central, it is related to your central nervous system. Okay, so it can be of your paracrine control is there. So when we say paracrine, it is histamine related control. Okay, you can have your neuronal control, that is by your acetylcholine, and then lastly you can have your endocrine control which is done by your gastrin. Okay, so you have three different controls. If you see it properly, it may either be paracrine, which is done by your histamine, acetylcholine. When we talk about acetylcholine, it is because of your neuronal control, and then lastly you have your endocrine control which is regulated by your gastrin, which is a hormone. So histamine, generally it acts on its own receptor which is your H2 receptor. Okay, acetylcholine, it shows its action by acting on its own receptor which is your M3 receptor. And then you have your gastrin, which is a hormone which reacts or which goes and shows its action by going and binding to your CCK2 receptor. Okay, so these are your hormone which are chemicals which goes and acts on its own receptors, and then thereby they go and control your secretion of your H plus ions through your parietal cell. Okay, so this entire diagram, okay, that you have over here demonstrates your regulation of your acid secretion. So first we will talk. So before I explain this in this diagram, first we'll talk about your neuronal control, okay, which is done by your acetylcholine, okay, neuronal control. So whenever you think about food, okay, you see food, you smell food, anything related to food comes to your mind, okay. So whenever that happens, what happens is your vagus nerve gets activated, okay. Anything related to food comes to your mind, your vagus nerve gets activated, and this vagus nerve in turn can regulate your secretion of your H plus ion. So how does it do that is, now you have thought about food, so your neuronal control gets activated, your vagus nerve gets activated. On activation of your vagus nerve, it is going to send an impulse and it is going to release your acetylcholine, okay. Now vagus control can act directly, okay, it can act directly and it can act indirectly and cause secretion of your H plus ion, okay. So you are thinking about food, you smell food, you see smooth food, anything related to food activates your vagus nerve. So on activation of vagus nerve, what generally happens is this nerve goes and it terminates on your, okay, in case of direct control, this nerve goes and it terminates near your parietal cell, okay. So it releases acetylcholine. This acetylcholine goes and acts on its receptor, which is your M3 receptor. So when it goes and acts on your parietal cell, it causes liberation of H plus ion. That is in case of your direct control, okay. In case of indirect control, what generally happens is, in case of your indirect control, you have thought about food, you smell food, anything related to food to your mind has come. Now there is activation of your vagus nerve side by side. This vagus nerve, it terminates near your ECL, okay, which is your enterochromaffin like cell. Entero entero enterochromaffin like cell, okay. So in case of what happens in your enterochromaffin like cell is, this acetylcholine being released from your vagus nerve, it goes and it activates your enterochromaffin like cells and it causes release of your histamine, okay. So your histamine is being released from your ECL, which is enterochromaffin like cells. So due to your release of your histamine, this histamine in turn goes and acts on your parietal cell and then causes liberation of H plus ion. So this is your indirect mechanism. In case of direct regulation of your acetylcholine, what was happening was, first vagus nerve was getting activated, your nerves, it went through, your acetylcholine was liberated, this acetylcholine directly went and acted on your parietal cell. That was a direct function. In case of indirect action, activation of your vagus nerve, the same nerve, it ended somewhere else, it went and it activated your ECL, which is your enterochromaffin like cells, it caused your secretion of your histamine, and this histamine in turn went on and acted on your parietal cell, thereby it caused release of your H plus ions. So this is how you get your neuronal control, okay. Second we are going to talk about your gastrin. Okay, gastrin, out of all these three, gastrin is your most potent inducer of your acid secretion. Okay, this is your most potent inducer of your acid secretion. It can be activated by your CNS through your CNS activation, local distension, or your content of your gastric contents can also activate your gastrin. And gastrin is secreted by your G cells. Now, same way, gastrin also has a direct control and an indirect control. In case of direct control, same thing, activation of your secretion of your gastrin takes place. This gastrin goes and acts on your parietal cell, and from your parietal cell it causes release of your H plus ions. This is your direct control. In case of indirect control, what happens is gastrin is released. This gastrin goes and activates your ECL, which is your enterochromaffin like cells, and then this enterochromaffin like cells, from your enterochromaffin like cells there is release of your histamine, and this histamine now goes and acts on your parietal cell and then causes secretion of your H plus ions. So this is in regards to your indirect control of your gastrin. Okay, but it has been seen that your release of your H plus ion is more through your indirect control than through your direct control. So indirect action of your gastrin is far more greater than that of your direct control. Lastly, you have your histamine. I've already told you how your histamine is going to cause release of your H plus ions. Okay, in case of histamine, histamine is getting released through your enterochromaffin like cell. Enterochromaffin like cell goes and acts on your parietal cell, that is your H2 receptors on your parietal cell, and because of which you get your release of your H plus ions. So this is your your regulation through your histamine. Out of all this, you also have another hormone, okay, which is your somatostatin. Okay, somatostatin, whenever your secretion of your somatostatin takes place, it goes and it inhibits your secretion of your it inhibits your secretion of your gastric acid secretion, as well as it inhibits your secretion of your gastrin. Okay, your main function of your somatostatin is to inhibit your secretion of your inhibit your secretion of your gastric acid, as well as it inhibits your secretion of your gastrin, your hormone itself, your gastrin. Okay, and this somatostatin is generally activated whenever your pH of your gastric lumen falls below 3. So whenever your pH of your gastric lumen falls below your pH 3, then there is secretion of your somatostatin. So whenever your somatostatin is secreted, it will inhibit your secretion of your H plus ions, as well as it is going to inhibit your release of your gastrin. So this is your function of your function of your somatostatin. So okay, apart from that, we have other secretions which is important in case of your protective role of your gastric mucosa. Okay, so in case of that, you have two different things. I'll show you in your diagram itself. So you have your prostaglandin I2 and E2. Okay, you have two important prostaglandins which help in your defense mechanism of your mucosal layer of your GI tract. So normally what your PGE2 and PGI2 does is, your PGE2 and your PGE2 and your PGI2, what these two prostaglandin does is, your PGE2 and PGI2 goes and acts on your epithelial cells of your GI tract. Okay, it is going to go and act on your epithelial cells. So whenever PGE2 and PGI2 goes and acts on your epithelial cells, what happens is it increases your secretion of your mucus and increases your secretion of your bicarbonate ions. Okay, you have your epithelial cells lining your GI tract. So in this case, in your stomach as well. So in this case, since we are talking about your regulation of your gastric secretion, so in this case, your PGE2, your prostaglandin E2 and I2, it goes and it acts on your epithelial cells, and when it goes and acts on your epithelial cells, it is going to increase your secretion of your mucus, as well as it is going to increase your secretion of your bicarbonate ions. Okay, so generally whenever your mucus is being secreted by your epithelial cells or your mucosal cells, when it comes out from your cell, it is generally soluble in nature. When it is secreted, it is soluble in nature, but as soon as it comes out from your mucus, it becomes insoluble. Okay, and then it coats your mucosal layer of your GI tract. Okay, if this is a mucosal layer, okay, your GI tract has a mucosal layer, submucosal layer. Okay, so your mucus comes out, it is soluble in nature. As soon as it comes out, it becomes insoluble in nature, it forms a thick mucus, so it goes and it coats over your mucosal layer. On top of that, your bicarbonate ions, okay, which is alkaline in nature, when this is getting secreted, it gets entrapped. Bicarbonate ions, okay, this is your bicarbonate ions. These bicarbonate ions, they get entrapped within your mucosal gel, so thereby this provides protection to your gastric mucosa through against your acid and your pepsin. Okay, so this is your entire diagram. So first one, okay, over here, this one, it is your gastrin going and acting on your ECL, that is your enterochromaffin like cell, causing your liberation of your histamine going and acting on your H2, causing your release of your H plus ion. Indirect control, direct gastrin going and acting on your CCK2 receptor, causing release of your H plus ion. Direct control. Acetylcholine over here, okay, acetylcholine going and acting on your ECL cell, liberating histamine, causing release of your H plus ion. This is indirect control. In case of direct control, you have acetylcholine. You have acetylcholine over here directly going and acting on your M3 receptor, causing release of your H plus ion. This is your direct control. Okay, on the other hand, what you have over here is your PGE2 and PGI2 acting on your epithelial cell, mucosal cell, which will cause your release of your bicarbonate ion, release of your mucus, bicarbonate ion getting entrapped in your mucus, thereby it provides protection to your mucosal layer. So this is basically your regulation of your acid secretion taking place in your stomach. Okay. So peptic ulcer generally occurs whenever there is an imbalance between your aggressive factor and your protective factor. Okay, aggressive factors are those factors which is going to cause damage to your mucosa. Aggressive factors such as a pepsin, acid secretion will cause damage to your mucosal layer, whereas protective factors such as your prostaglandin E2 and your I2, mucus and bicarbonate secretion, mucosal blood flow, rapid turnover of your gastric mucosa is going to protect your mucosal layer from damaging your mucosal will protect your mucosal layer from getting damaged. So whenever we talk about your mucosal blood flow, okay, uh, your metabolic activity of your cells of your GI tract, okay, your epithelial cells is very high. Your metabolic activity of your GIT is very high, so they always need your there is always a high demand of oxygen as well as nutrients taking place. So if your mucosal blood flow is good, then there will be less damage occurring to your mucosal layer, as well as your epithelial layer of your gastric mucosa is changing tremendously at a very high rate. There is apoptosis occurring at a high rate in your case of your GI tract. So if blood flow is good, then it will also support in your rapid turnover of your gastric mucosa as well. Okay, so whenever there is an imbalance between your aggressive factor and your protective factor, that will lead to peptic ulcer. Generally, there is the aggressive factor which is balanced by a protective factor. So whenever your protective factors of your GI tract is optimum, these aggressive factors cannot go and damage your mucosal layer. But if there is if there is if there is a decline in your protective factor, then it will lead to damaging of your mucus or your mucosal layer of your gastric tract, you can say of your stomach, of your duodenum. Thereby you get your peptic ulcer. Okay, so an imbalance between your aggressive factor and your protective factor will damage your mucosal layer and then cause peptic ulcer. So etiology, your etiology of your peptic ulcer can are of many types. So Helicobacter pylori, this is a gram-negative bacteria, and it has been seen that 15 to 20% of people suffering from Helicobacter pylori, they generally develop peptic ulcer. Okay. Second is NSAIDs. NSAIDs, they are drugs which is non-steroidal anti-inflammatory drugs. Okay, non-steroidal anti-inflammatory drugs. Okay, so NSAIDs, they can block your COX-1 as well as it can go and block your COX-2. If you go and block your, if it blocks your COX-1, then your prostaglandin if it goes and blocks your COX-1, then generally what happens, your PGE2 and I2 will not form. Okay, we are talking about NSAIDs. These are non-steroidal anti-inflammatory drugs. They go and they block your COX-1 and it will also go and block your COX-2. So blocking of your COX-1 will lead to decreased production of your PGI2 and PGE2. So if these two are blocked, then it will decrease the secretion of your bicarbonate sign as well as decrease the secretion of your mucus. Acid pepsin secretion. So for your peptic ulcer to develop, there has to be some level of secretion of your acid as well as pepsin. Without any secretion of your acid or your pepsin taking place, your peptic ulcer will not develop. Gastritis. Okay, in case of gastritis, worse, if your gastritis becomes chronic, it can lead to peptic ulcer. And it has also been seen that peptic ulcers, whenever someone is suffering from peptic ulcer, he or she suffers from some different kind of gastritis, or some level of gastritis is always there. So if gastritis becomes chronic or it worsens, then it can lead to peptic ulcers. Okay, local irritants, inflammation will occur, so that inflammation can further damage your GI tract. Dietary factors, deficiency in food, nutritional deficiencies has also been shown to develop or has shown to lead to your peptic ulcers. Psychological factors, stress is an inducer of your peptic ulcer. Okay, stress. Genetic factors, though not very common, in some cases genetic factors can lead to peptic ulcer. In case of your hormonal factor, secretion of some hormones. Okay, secretion of some hormones has shown that it can lead to peptic ulcer. So tumors in your pancreas. Okay, tumors in your pancreas can lead to increased gastric secretion as well. Okay, so this is generally your Zollinger Ellison syndrome. Zollinger Ellison syndrome. It has been seen that this is generally a tumor in your pancreatic cell. Whenever this occurs due to a tumor occurring in your pancreatic cell, there will be increased secretion through your pancreas, which will in turn lead to your peptic ulcers. And lastly, there are miscellaneous causes for your peptic ulcer as well. So this is your normal gastric mucosa. Okay, this is your normal gastric mucosa. Okay, see, in case of your normal mucosa, since there is your balance between your damaging forces, okay, even though your damaging forces are being produced, your defensive factors are protecting your gastric mucosa from being damaged, correct? But in case of your injury, okay, now you have different etiological factors. You have your infection, NSAIDs, smoking, cigarette, alcohol. Okay, now in this case you have your increased amount of aggressive factor is there, whereas side by side you have decreased your protective factor by ischemic shock in your gastric tract. Okay, delayed gastric emptying. Okay, other factors. So all these factors leads to decrease in your protective factors or your protective forces. Since there is decrease in your protective factors, your aggressive factors can easily go and damage your gastric mucosal cell. Now since there is going to be damage to your gastric mucosal cells, you get your ulceration in your mucosa of your GI tract. One main thing is your action of your H. pylori. Okay, so we will talk about the action of your H. pylori and how it helps in your damaging of your gastric mucosa. I already told you that H. pylori is a gram-negative bacteria. Okay, this is your gastric mucosal layer. which is now protected by your mucus layer, and your this is protected by your thick mucus layer, correct? This is your gastric mucosa. So in this case you have your bacteria over here. Now since bacteria, they have your flagella, okay, this bacteria, they have your flagella. Due to your presence of your flagella, this H. pylori can move through your mucus layer, correct? Flagella helps in the movement of your bacteria, so H. pylori has a flagella and it enables your bacteria to move through your mucus layer. So one important thing about H. pylori is H. pylori it produces an enzyme which is known as your urease. Okay, H. pylori produces an enzyme which is urease. So urease converts urea into ammonia. So your action of your urease enables your conversion of your urea into ammonia. So when your ammonia is being discharged, okay, I hope you understood it, your bacteria produces an enzyme urease which converts your urea into ammonia. So this discharge, this ammonia being produced, what your bacteria does is this ammonia goes and it coats your bacterial layer. Okay, your bacteria is getting a coat from your ammonia. So whenever it gets coated by ammonia, since ammonia is basic in nature, your bacteria gets protection over your HCl being secreted. Okay, your harsh acidic environment now cannot cause damage to your bacteria because now it has a coating of ammonia over it. So after it gets a coating of ammonia over it, and on top of that it has its own flagella. Now this bacteria, what it starts to do is it starts to move. Okay, it is going to move through your mucosal layer. Okay, so it is going to move through your mucosal layer, and then it will, when it reaches your surface of your epithelium, it goes and it adheres itself on your surface. So after it adheres to your surface of your epithelial layer, it is going to propagate, or it is going to multiply as well. Okay, it is going to multiply. So as it moves through your your mucosal layer, it is damaging that particular portion of your mucosal layer as well. Okay, so other areas is having your mucosal layer, but your area from where your H. pylori moved into you get your damage in your mucosal layer. So in this case, this particular area is now exposed to your HCl, it is exposed to your pepsin. So your HCl and pepsin can easily come and attack and damage your mucosal layer. So there is going to be damage of your mucosal layer. So this is how your H. pylori helps in your causing of your peptic ulcer. Apart from this, your H. pylori is a foreign substance, correct? It is an foreign substance, it is an unwanted particle. So your body is going to send your macrophages, it is going to send its defensive role. So macrophages will be sent, okay, your leukocytes will be sent. So in turn, this macrophages, your leukocyte, will also help in your inflammation of your area, this area where your damage is taking place, and side by side your inflammation can further deteriorate your mucosal layer as well. Okay, so till here I think it's clear. Flagella, it keeps on moving through urease, ammonia being produced, coats the bacteria. After coating occurs, it moves into your bacteria, your mucosal layer, adheres to your surface, multiplies. So it is going to release its own chemicals and then destroy your layer of your mucosal layer. Apart from that, the other thing is your body is going to send your macrophages, your neutrophils, and this in turn is going to release its inflammatory pro-inflammatory mediators, increase your inflammation, and side by side, in order to kill your bacteria, they also damage your mucosal layer as well. Lastly, your H. pylori, what it does is, now since H. pylori is releasing ammonia, correct? Ammonia is basic in nature. Since it is basic in nature, it is going to do what? It is going to increase your pH. Since there is increase in your pH, one thing that it is going to inhibit is, it is going to inhibit release of your somatostatin. If your somatostatin is being inhibited, then there will be increased secretion of gastrin taking place side by side. So if there is increased secretion of gastrin, the H plus ion secretion is also going to increase. So H plus ion getting secreted more means more acid being produced. So this acid will again in turn cause further damage. So this is basically how your H. pylori helps in your formation of your what you call it, or of your peptic ulcer. Okay. So lastly, you have your complications in association of your peptic ulcer. Complications in association of your peptic ulcer is gastrointestinal hemorrhage. So you are eroding your mucosal layer. So whenever your erosion reaches your submucosal layer, so if your damage occurs till your submucosal layer, if your damage reaches till your submucosal layer, then there is going to be bleeding. So that's why you have your gastrointestinal hemorrhage. So mucosal layer damaged, you reach to your submucosal or even deeper, that will lead or cause bleeding in your gastrointestinal tract. So that is your gastrointestinal hemorrhage. Second is your chronic iron deficiency anemia. Since you are bleeding tremendously, you are losing your iron. Okay, so since you are losing your iron, you have your iron deficiency anemia occurring. Pyloric stenosis. In case of your damage occurring near your pylorus, right, there is damage and your scar formation. Okay, scar formation takes place. Okay, it's not over here. Okay, there is your damage to your pylorus, okay, near your pylorus, and due to your damage and healing taken place, you have your scar formation near your pylorus. So this scar formation will in turn can lead to pyloric stenosis, as well as there can also be hypertrophy of your pylorus taking place. So this can also lead to pyloric stenosis. And lastly, you have your perforation. Perforations, they are your holes which occur in your walls of your gastrointestinal tract. So perforation is an acute emergency case which has to be treated as soon as possible. in case of your peptic ulcer. So these are your complications in relationship to your peptic ulcer. So with this we complete another topic. Thank you everyone.